Good afternoon, everyone. Thank you for joining today's webinar. Today, we're going to be talking about real-world success achieved by The Ohio State University in reducing their door-to-balloon times, specifically in the emergency department. Thank you all for joining today's discussion. I will be serving as the moderator for this session. And by way of introduction, my name is Rory Nellis. I serve as the Chief Commercial Officer of Airstrip Technologies. And for those of you who might not be familiar with our platform, we are a native mobile and web visualization tool that automates clinical workflows across patient monitoring, cardiology, and obstetrics. And we are used by thousands of clinicians every day in about 600 hospitals across the United States. As for some housekeeping items before we get started, just know that we are recording today's session and that will be distributed at the end. And we will also be monitoring questions as they arise in today's session. You can place those in the bottom of your screen. And without further ado, I'm going to transition over to Patty Blake from The Ohio State University, along with Dr. Eric Atkins.
Welcome. My name is Patty Blake. I'm a senior cardiovascular quality manager, and I'm responsible for tracking data in the field of cardiology and reporting this information back to the physicians. I'm going to let Dr. Atkins introduce himself.
Yeah, thanks. Eric Atkins. One of the Associate Chief Clinical Information Officers here at OSU. I'm an emergency physician, and I work in I have a side of me that works as an intensivist after completing a pulmonary care fellowship. And would just like to clarify, there's no conflicts. I have no relevant conflicts for this talk.
Okay. Just a little bit of background about Ohio State. We are, in the U.S. News and World Report, ranked the #1 hospital in the city of Columbus in Ohio. And we also achieved some recognition for at least 9 other specialties as far as having the U.S. News and World Best Hospitals report. We're located, of course, in Columbus, Ohio. We are an academic affiliated hospital. We have 5 hospitals with a total number of at least 1,500 beds or more. We're actually building another building as we speak. The emergency department currently sees more than 70,000 patients per year. And the size of our emergency department actually expanded after I started working at Ohio State to the size of 2 football fields. So that footprint is really big, and that's kind of important to this process. So the background to this is, of course, the American Heart Association guideline says that 12-lead EKG should be performed and shown to a physician within 10 minutes of arrival if the patient's having an ST elevation acute myocardial infarction. So it's really crucial. You can't treat the patient unless you're making a STEMI diagnosis. So that EKG is crucial to this step. And a shorter door-to-balloon time actually has a better patient outcome. We did notice that a door-to-balloon time of less than 60 minutes is associated with a lower 30-day recurrent myocardial infarction and 30-day mortality rates in the literature as well. Initially, we belonged to the ACTION registry, which is part of the American College of Cardiology, NCDR. It's one of their registries. And in that registry, it was really tracking more the upfront process in the emergency department as well as what the EMS was doing. And so one of those metrics was door to first EKG time. And like I said, the national benchmark is to obtain that EKG show to the physician within 10 minutes or less. And we were consistently at this time, back when we were doing the ACTION registry, only really achieving that about 63.7% of the time. But if you actually look at hospitals at the 50th percentile, they were 68.5% of the time. So nobody was doing it extremely well. And we wanted to actually find out a little bit more around this process. So one thing we did was an observational time study. From that, I actually created a process flow map, and then we took a look at the data and drilled down on patients. We looked at time of day, we looked at volumes in the ED, we looked at whether or not staff was available to complete the EKGs and take it to the physicians in a timely manner, was the physician available, and other contributing factors as well. Not that you can see this real well, but this is my actual flow chart. So this is one of the quality tools we do in order to track from the patient to registration to triage to the physician and so forth. And so wherever there's a diamond when you're looking at a flow chart, somebody had to make a decision. And when they make a decision, it stops the process. We really want this to be a step-by-step process. So each of those represents whether or not there were patients waiting in line to be seen, whether or not there was staff available, whether or not a physician was available in this process. And although this is a fairly busy slide, this is the footprint of the emergency department. And Dr. Atkins, you might want to comment on how many areas where physicians actually sit. Don't know if
Yeah, sure. We had 4 spaces here that the docs were sitting in. At peak times, we would have about 5 physicians working, as well as the typical resident cadre and APPs working with us. But it made for a lot of kind of walking about from the individuals to go find us, especially if we're not sitting at our workstation and we're actively involved in clinical care at the time.
Okay. So I actually went down and observed 38 patients. And then I took a look at 1 month of data. The time of day I picked to observe the patients, we decided had to be the busiest time of the day in the ED. So I went anywhere from 1 o'clock until the evening. And one patient we actually did have during that time frame was an actual STEMI. So our baseline metric for this very small study of 38 patients kind of told us a little bit about the process and the fact that it took 7 minutes to prep the patient, which included, getting the patient dressed, undressed, on the table, doing the EKG, and they had to actually, at that particular time, type in the patient's name and information into the machine. And then once it was completed, we had to go find the physician. And like Dr. Atkins said, if you look at that last slide, there's just so many different areas that the physicians could be. It took a while. So on average, instead of that 10-minute benchmark, we were averaging 14 minutes. And every single EKG is shown to the physician for signature, not just STEMIs. So this really amounted to a large amount of time by the staff. In fact, over 2,400 ECGs are completed in a month, or 82 a day. And we averaged the time for that, and that was about 9.5 hours of every 24 hours that somebody was spending just walking and trying to find a physician for signature. That's one person's shift. So the first thing we did was to look at the machines and say, can we bar scan, for a couple reasons. It really more accurately identifies the patient, and it reduces typing errors. It reduced the time for entering that into the EKG machine or the ECG machine. And then it helped us to accurately merge that ECG order in Muse to that one that was actually being stored. So bar scanning was a big first step. And then we had a meeting and we began talking about how can we more rapidly deliver this ECG to the physician. One guy in our meeting said, there's actually a phone app that can do that. And we all said, there is? How's it work? And so it sends the ECG electronically to the physician via their phone and or iPad. Some physicians preferred to use the iPad, so we put it everywhere where a physician might be sitting, and they could actually electronically sign these ECGs if desired. This is a HIPAA compliant app, so that acknowledgement of the ECG using that app is secure. And it definitely eliminated the time in finding the physician to review and sign the ECG. And of course, they can electronically sign that ECG with the timestamp and the physician's name. So we really moved from this antiquated system, well, not really this, but we really moved more towards this. So I'm going to let Dr. Atkins take over.
Thanks, Patty. That was a great summary. So just wanted to give you guys just kind of general look at how we approach this from the physician perspective. This is an example of our workstation that we use in the emergency department. You can see on the left-hand side, we have an iPad mounted in the metal case with the touchscreen up in front of it. We're going to show you some screenshots that are going to come from the almost like an iPhone view, but the phone view and the iPad view are going to be very similar as far as how it looks. Obviously, just going to be a little bit larger on an iPad screen. So you see the Airstrip 1 app here towards the middle, just a simple tap. This is going to come up, and then if you're working in a site that has multiple different hospitals that may have been segmented out, you would click on the area that you wanted to be able to view. One of the nice parts about using the iPhone functionality has been some of the biometric features. So if your institution is using things like biometric features to be able to enable login, this is really nice with either the fingerprint that had been previously on there, or you can use the Face ID as well now. You'll get in. While you're in, you may occasionally receive notifications. And so these are going to be notifications that are going to come to you once it's been interpreted by the Muse process. And then it'll instantly push over to Airstrip, and you'll get the notification. So you can easily look at this. This is a nice feature that if you're working with your cardiologists as well within an organization, that if they're going to put something like this on their devices, they can actually see these STEMIs as they come up. This is something that's also been able to be customizable. So if you're worried about getting too many notifications, occasionally you may get that false positive that Airstrip or Muse is telling you that could be a STEMI. I think many of us have looked at those EKGs and then looked at them again and say, I know it says STEMI, but realize that it's not. Easily, though, you tap right on the notification, and it should take you to the EKG. Once you're in, you'll get this type of view here. So this is again on the iPhone screen. And depending on how you feel about using the size of the device, it's still very usable, I think, on the iPhone. It's got a nice feature to where if you tap twice on the lead, you'll take up the whole screen, as you can see here on the right. And then you can customize the amount of screen that you're going to be able to see and focus in more on the waveforms if you want. It's easily closed, and it'll take you back to the screen on the left. And then as you scroll through it, you can see all 6 seconds of the lead that was acquired. If you're wondering, can I look at other EKGs to be able to compare? Because I think we all know that comparison EKG is essential in the clinical work. You tap on the ECGs at the top left, and it's going to give you an option to look at multiple EKGs. So here you are going to see that it's going to show you an older one. So if we're looking at, in this case, you would be seeing the most recent one from 6:19 on this day. There's one done at 5:18, an hour earlier. You tap on that, and it's going to show you both. In this case, on the right-hand side of the screen, the top is going to be the first ECG, and the bottom is going to be the second. And as you scroll, all the windows will move and flow with you. We can demo parts of that towards the end if that would be helpful for folks. There's also a nice dashboard for the staff. So the techs and the nurses that are working and acquiring these ECGs, they're able to see which docs are signed in, and then the ones that would be signing off on these. They can also tell if they've been signed yet or not as part of that process. So sometimes they just need to ping, one or all of those docs to remind them that there may be a couple ECGs that need to be signed still. This has been a great feature when you think about the impact on patients and on staff. This helps to speed up that line as people are coming through with acquiring their ECGs very quickly between the barcoding. It's also nice where the staff aren't spending a lot of time pursuing or chasing the doc around to get somebody to sign it. Even just the amount of time having to stand, maybe hovering with a doc if they're staffing resident cases or APP cases, to reduce the number of interruptions that come to the physician. So it's easier that you're able to sit there, focus on the work that you're doing, and then be able to pivot to something like the iPad to be able to sign off on it. There's also functionality that you can see Airstrip within. If you're an Epic organization, it integrates well with Epic, which is what we use. We haven't taken the integration yet, but it's something that's possible to be able to view it within that web browser viewer, or even within the Epic, one of the Epic panes as well. I think one of the nice parts as an emergency physician has been the ability to look at those be able to see that old ECG really easily. And it's not just having 2 ECGs, you have patients that have 10, and you want to look back through a number of those, it's really nice to be able to do that. It's also helped, I think, with kind of trying to distribute some of the workload of signing off on multiple ECGs. As you know, if you're a single physician working at a smaller emergency department, a lot of things going on, and you may be the only one signing off on those ECGs. But if you've got 2, 3, or 4 docs working at the same time, it's a good way to try to distribute this amongst each other. And you can even also share back that data with various individuals to show them what the number of EKGs they're signing per hour worked, so that it kind of helps to level that playing field and kind of normalize it for folks. Or you can just choose to say you're the ECG doc today, and so there might be 2 of you, 3 of you working, but if you're working in an area that allows for more real-time access to keep up with the ECGs, you can be that person that's just allocated to be signing off on the ECGs that day. Other nice part, I think it helps with the staff when they're trying to come back and reconcile some of the ECGs from a data entry perspective. It avoids the loss of other ECGs and kind of the billable encounter aspect of it, where it doesn't just kind of go off and disappear as what I would almost call like a ghost ECG, where some of the data is missing, and then you're having to reconcile that data later on, which can be a very manual process. Here's some of our data that I just want to show you. This obviously goes back, during COVID into that January 21. It's about 14 or 15 months worth of data. We've consistently been able to sign the ECGs in less than 10 minutes, 100% of the time. We had a number of zones that we had broken out in our clinical footprint that we had listed on the left-hand side. You can see where it's kind of called the arrival zone, the oncology zone, west and central. These broke down into right around 2 minutes, for the fastest ones, about 7 minutes for the people that were a little bit longer, but we averaged right around that 4.5 minute mark for being able to sign and interpret the ECGs. This data has continued to prove out as we've gotten into the last 5 months of this year, from January through May of 2023. It's narrowed just a little bit. We're under the 7 minute mark, but the mean and the median have stayed essentially the same. I think when you start to try to compare this and some of the impacts from this, we look at what the door to balloon time metrics have been. This is looking back over the calendar year for 2022. Some data from this is from quality improvement. 90th percentile was at 51 minutes. We were able to get down to 38 minutes, which I think we're really proud of, being able to have such a low door to balloon time. We looked at some of the mortality comparisons, pre-airstrip and then post-airstrip. There's a big change that came here post-airstrip. I think some of this may be 1 or 2 cases that really inflated some of that door to balloon time early on. But either way, we can show that before airstrip, we were around 63% of our door to EKG time at less than 10 minutes. After the implementation, we were able to get down to 100%, which has been really nice. I know a couple of questions have popped up in the chat. I'll get to those here in just a second. But just in summary, this is, I think, the impact of a process improvement project. One of the challenges and this may get to one of the questions, was really having a good team, where having the courage to kind of step forward and say, we need to do this. Initially, a lot of the docs, the staff, they didn't totally love it. It was a huge change when we got started, to getting people to kind of evolve to using a digital process as opposed to relying on a piece of paper being put in front of somebody's desk. Over time, we were able to get more and more engagement with this, and we've seen pretty good uptake. And we've gotten into that top 10% within the country for our door to balloon time, resulting in reduced mortality for our patients with a door to balloon time of less than 60 minutes. I think one of the other parts that was really important about this is implementing something like this in the middle of COVID. One of the byproducts, I think, of a process like this is everybody moved to a digital and telehealth process. Obviously, this wasn't something that we were necessarily planning for at the time, but we were happy to be able to have a way to kind of reduce the amount of person-to-person, interaction and that handoff where you start to risk other exposures that people may have while they're at work. So I see a couple of questions in here about explaining the implementation process. As we started to implement things, one of the ways I started with, I got a small group of docs. We had 5 to 8 of them. I got them all access to Airstrip. We had some of the tablets placed. Many of them use their own personal devices, and I would just have them try it out. I say, try it, see how it works when you work on your shift. You know, somebody would continue to bring paper ECGs to them, but they would just use their device. Got their feedback about how they felt, you know, what they felt like the pain points were, was it feasible? And as time evolved, it seemed like that was something that would work, and we saw the value of that. We came to a time where we rolled out, you know, across the entire department. The techs found it a huge satisfier to suddenly not have to chase down the docs, and that allowed them a little bit more time to help focus on supporting the nursing staff and other types of patient care. Of course, as we got started, it wasn't perfect, and it required a lot of kind of on basically like monitoring as we went. I would spend a lot of afternoons and evenings, and Patty would do the same with us, keeping an eye on our own Airstrip application to see how many EKGs were signed or not signed. And we'd have to have some days where I'd be messaging individuals that were working and say, hey, could you please, you know, address the Airstrip stuff? One of the other nice advents of things like Secure Chat was really helpful because I could get on, you know, from basically anywhere, and then Secure Chat the team that was working to say, hey, can you guys take a look at the Airstrip stuff? And even ask them questions like, are your iPads working? Is there anything wrong with Airstrip? And often the answer was no, everything's fine. And I was like, great, can you guys please make sure you're signing off on the ECGs, and just getting them into that habit. And now that it's evolved to, as we trade off physicians that are staffing in the department, whoever's coming in to kind of take over that workstation, one person's logging out, another person's logging in as they start to take handoff. I see another question here about what's adoption been like. So this is just in our emergency department now. The cardiologists have it. Within our group of emergency physicians, we've got about 80 emergency physicians here at our department. We have 2 departments. We have a smaller one that we refer to as our East Hospital, and then our university campus has the larger clinical footprint. Between the 2 sites, we've got about 150,000 visits a year, right around 130 to 140. The East Hospital we haven't brought live yet due to some other just strategic decisions that we made at the time, but we're looking to do that in the future. Let's see. I see a question here about change management. I think the biggest challenge with change management was just keeping it front and center with the providers. I think the nurses really appreciated it, especially as you got them over to barcoding. It made life a little bit easier for them, and then just trying to stay in front of the docs and be willing to hear the critiques and the criticisms that came up. There are some people that like clearly they didn't like it. We did see at one point when we broke things out into the zones, they were able to see EKGs that were coming from their zone, and a couple of the docs would decide that if they weren't working in that zone, they weren't signing some of the other ECGs. We later took that off so that they wouldn't see actually where the zone was, and it was just a matter of if you had, 2 minutes and there were 5 EKGs to sign, you signed off on those really quickly and didn't think about, was it my patient or somebody else's patient? And frequently, as you know, if you deal with boarding in your institution, you would have to manage those patients that were coming in through the lobby. And so you got to make sure somebody's looking at those ECGs on a real-time basis. Let's see. Does Airstrip have other mobile technologies other than 12-lead ECGs? Rory, I'll pass that off to you and let you answer that one.
Yeah, we do have other technologies outside of 12-lead ECGs. As I mentioned earlier on, we're used throughout patient monitoring, oftentimes by bedside nurses, monitor techs, as well as providers across the inpatient, ICU, step downs, telemetry, med surg departments. So that is definitely another use case for our application, whether that's via the mobile device, as we've been speaking about on an iPhone or Android, but also on the web application or a full PC browser. We are also utilized across the obstetrics department for labor and delivery to bring those streaming maternal and fetal strips directly to the end users in those environments as well.
I'm going to take on this other question about, is AirStrip a scanner that attaches to the ECG machines? It doesn't attach to anything, so it's like a middleware type application. So once you've acquired the ECG through your machine, it hits out to your Muse, and then it's going to run through AirStrip, and that's going to be available in AirStrip. It's milliseconds. There's not a delay as long as you have a strong network. I think everything works pretty well with that. Rory, do you want to comment on the integration with like GE, Philips, et cetera?
Yeah. So we're a platform that does connect with the major monitoring vendors in the space. So for GE, it's GE bedside patient monitors that are in those inpatient departments, as well as the GE Muse system, which is the electrocardiogram repository. And then we also connect to the Philips bedside monitoring system as well. So we are vendor agnostic in that regard.
I think it's great questions for those of you that have been bringing them forward. I appreciate that. I know that I think we had allocated about 45 minutes or so, for the session, and try to get through most of the questions that have come through. If there are other questions, feel free to put them in the chat. I think as part of this goes out, if people have other questions, you're welcome to email me. Just for quick comments or questions if you want, or reach out to Rory as well, and be happy to talk with others at some point if they would like about our experience with the application.
Perfect. And Dr. Atkins, while we have the time, would it make sense if I were to share my screen and kind of show the live application?
Yeah, I think that'd be nice. You can kind of see how snappy it is, as you move between the various windows.
Very good. Let me just switch over here to share my screen, and let me know once you're seeing, you should be seeing my iPhone up.
Yep, we see it.
Awesome. Well, this is my iPhone. So this is my personal device, as this would be similarly installed inside of a health system on providers' devices. If there are shared nursing phones, the same rules apply. Those get rolled out to the shared devices. So when I touch on my demo environment, which is using demo patient data here, you can kind of see how easy to use the application is. I'm going to select on the menu tree at the top left here, which is where Dr. Atkins and his colleagues access the 12-lead ECGs coming from that source system, which would be the GE Muse in this case. I'll just simply click on the most recent ECGs to bring up those that are waiting for the electronic acknowledgement. And in here, you can see a large list of those ECGs. So these are the patients that have 12 leads in the system. And then on the right side here, you can see the number of ECGs that are there from a current presentation state or historical within the Muse system. I'm going to select on Martina here as our demo patient and kind of show the interaction there. So when I click on Martina Gonzalez, you can see some basic information about her in terms of female, her age, some identifiers about the patient, as well as that there are 3 ECGs in the system for her. So when I select on that patient, you're brought immediately to the most current ECG. So Dr. Atkins, this should look pretty familiar to you here. Where now I have the ability to navigate the application. So by selecting this down caret here, I have the ability to pull up what the Muse interpretive statement was, which would be an unconfirmed reading of this ECG. I also have the ability to transition this into what we call landscape mode. So this would be the ability to give a little bit more real estate if I'm an iPhone or Android user here to interact with this 12 lead.
This is a really nice feature, Rory. I think that like when we're in the landscape mode, I think a lot of us like that. If you're using a personal device, it works really well.
Yeah, we've certainly got that feedback quite often to give, again, a little bit more real estate to really assess the leads that are needing to be looked at here, where, again, I'm using my finger on my phone here just to interact with this information. If I needed to come in and do some lead isolation, say on lead 2, I can simply double tap that, which will, again, blow that up for me, where I'm allowed to then scroll along the rhythm and potentially zoom in and zoom out as needed as I'm assessing the ECG. So as Dr. Atkins also referenced earlier, is the ability to compare this to a prior ECG. So now I'm going to long press on the second one in the list, which is going to bring them up in a side-by-side mode, often referred to as serial presentation. And in here, I can view the current ECG as well as a prior 12-lead record from the Muse system. As then I hit the back button, it now might be time to take some actions on this ECG, as we've talked about in the case of the Ohio State University. And these are customizable actions we can take here. But if I select on these 3 dots up here, it will allow me to acknowledge. So I'm going to go ahead and electronically acknowledge this ECG and maybe make some decisions from that. So for now, I'll just select the yes button here with no comment. That would give me the confirmation that I have, in fact, electronically acknowledged this ECG with the date and timestamp.
Roy, you want to try one other one and just show the pinch and zoom, like as you're in that, just how much it blows it up.
In terms of this view here, or into an individual?
Yeah, just like right there. If you just pinch and zoom on B2, I think it'll blow the whole thing up without actually getting into it. If you stay out of it, I thought it would.
Yeah.
Let me go back. Screen.
Yep. Let me just go back into Martina here, and let's see here. Pinch. That's allowing me to do lead isolation here. Inside the full list, let me just go back here to, let's try a different ECG. Again, this is some demo data here, so it might be slightly different. If I can pinch and zoom down here. There we go. So instead of lead isolation, I can pinch and zoom out on all leads for the 12 lead.
Eric, I think you're talking about you can do it with your finger, like on your iPhone. You can stretch it out and look at it, right?
Yeah, it's just it's a nice feature, I think, for folks, because everybody wants to see, maybe a little bit more detail at times, or they want to see more of a pulled out view. I think if you get in the landscape view, Rory.
Yeah.
And then just try to like pinch and zoom on. Yeah.
There we go.
There you go. Yeah.
You can do it just on lead 2, or double tap to select another lead source and then scroll down here as well. So again, this is sort of that native mobile app environment where it's going to allow the end user to kind of assess based on their preference. One other thing that I'll show here, I think what was one of the questions, is there other input systems into the Airstrip application? So again, I'll kind of back out of Martina and go to our patient navigator section, where you can see we have the ability to pull in additional sources of information coming from other points of integration, maybe the monitoring system at the bedside, maybe obstetrics, or the EHR, whether you're using Epic, Cerner, or other, and pull that information in. And so one of the areas that we're very commonly used across the inpatient side of it is the actual patient monitoring system for ICUs and/or telemetry departments. So by clicking on the monitor button here at the bottom, it's going to take me into the live streaming view of what's happening now inside the patient room. Of course, Martina here has only got a couple parameters here on the bedside monitoring system, whereas if I were to come into another patient, say George Russell, I'm able to then see a little bit more lead sources based on him being an ICU level patient. So again, I'll hit that monitor button there, where now I have the ability to kind of do the same things we do on the 12 lead. So if I needed to pull this into landscape mode, give more real estate, we can do that. We also have the ability to go back in full disclosure here by using our finger, or simply navigating through the clock icon to a specific moment in time. With this, we've also developed the ability to measure leads. So if I need to take a measurement of this lead source and document that in with a rhythm strip interpretation to the medical record, we can create what we call a snippet, which is going to take these measurements based on my caliper placement and allow me to annotate this and directly save this into the patient chart. I'll just type AFib as an example. And once I hit save, that's going to then go into the Epic system as an electronic PDF. Of course, my system's not hooked up for that, so I can only show you so much in the live demo environment. But these are some of the conversations we've been having with OSU in terms of expanded use cases beyond the emergency department. So hopefully that helped answer some of those questions in the chat.
Let me just add that if a patient is having a STEMI, quote unquote, read on the ECG, we spent some time actually picking a very unique sound on the phone that would alert the physician, something that's not your normal iPhone or any other sound that you might hear for a text or anything like that. That sound is pretty unusual. And I'll tell you that when we went live, I was actually out in South Dakota, and I got that sound in South Dakota.
Yeah, that's really great to hear about. So, and a good point also to mention. So, regardless of the end user's physical presence, you have access to these ECGs wherever you are. Dr. Atkins, do you find yourself accessing the system from outside the hospital, or is it primarily used within the four walls?
My use of it outside the hospital is just to make sure that it's working and everybody's using it. So it's nice to be able to know that from afar that it's going okay. But generally, I'm using it internally when I'm on shift.
Yeah, I was monitoring use to make sure things were getting done early on. The other thing I will tell you that if a patient has an ECG done anywhere in the OSU system, physician office, whatever, those are always stored in the Muse. And so when they're pulling up ECGs to compare, they'll be able to see any ECG that was done anywhere within the OSU system.
That's great. And then do you have this today integrated with multiple campuses across OSU? I know that the health system itself is rather large, but are you only integrating one of the campuses, say Wexler Medical Center, or do you have other satellite emergency departments that are connected into the system as well?
It's primarily at the University Hospital location. We're looking at opportunities to bring it out at the East Hospital location as well. But we're able to we have a couple other kind of non-ED based locations that we help cover clinical care for within the larger hospital to care for some of the oncology patients. And we're able to route those ECGs from those machines into our version of Airstrip so that we're looking at them and signing off on them as well.
That's great.
And actually, the Wexner Medical Center is the flagship. It's the largest of the hospital system.
And you said there was about 100 beds in the emergency department?
We can go up to about 116 treatment spaces. So it's 86 physical beds plus a number of hallway or vertical waiting areas.
Certainly a large operation. That's one of the questions we oftentimes get is how does it get designed from a kind of a human factors engineering standpoint when you have a large ER? And one of the things that I'm not quite sure how unique it is, but is having it broke out into those sort of pod departments that you talked about earlier, which seems to have really impacted like the ability to kind of work within, efficiently within those given pods. And so it's really great to hear that you have those iPad workstations available within each of those pods to shorten down the number of physical steps needed to be taken.
Yeah, it's been really useful.
Well, great. I'm checking back in here to see if there's any additional questions, which I'm not seeing on here. So I know we're about 38 minutes into the session. Any other comments, Dr. Atkins or Patty, from your perspective?
No, it's been great. Have appreciated working with you guys. We've spent a lot of time working on this together. Have appreciated kind of the growth over the years and the adaptation of the application to help meet, the local needs for our group.
I just want to add that, you have to have leadership at the top to do this. And so I appreciate Dr. Atkins' leadership because he really did drive this. And without his leadership to get all the physicians on board, to help nursing feel comfortable, we wouldn't be where we are today. But I told Rory earlier, this is our norm. This is how we operate every day. And the staff was really, really grateful not to have, or at least to have some extra time back in their day to take care of patients. So
Thanks,
we
Patty.
really appreciate this.
That's nice. I think the one other thing that maybe I point out to individuals is just for anything that you're doing electronically within the IT world, you got to have a downtime process. And, we don't love it, but our downtime process is just we go back to the old version. So if there's ever any glitches, kinks that pop up, it's very easy to kind of switch back to downtime and basically go paper. But it's usually short-lived when we have to do that.
Yeah, we get that feedback quite a bit. Is downtime is essential, and then once you've kind of got the reliance on the technology and you see how the downpact is impacted, you kind of find out that how well it's been adopted or not. So that's good feedback to get as well. Well, I just want to say thank you all for your time and partnership as well, for embracing technology. I know it's not always the easiest to introduce to a large health system, but we feel proud to be partners with the Ohio State University, certainly in playing our little role here in how can we leverage technology to expedite care processes. And so we're super proud of our work that we've done and thankful that you all have gotten behind it and really embraced it to improve metrics and outcomes. So really, thank you.